Welcome to Computational Genome Biology. Today, we are exploring urticaria, pathogenesis, epidemiology, and clinical management. Urticaria is a systemic inflammatory skin disorder with a significant epidemiological footprint. The lifetime prevalence is estimated at up to 20% across the global population. This patient exhibits the primary clinical manifestation, the development of transient, intensely itchy raised wheals. These lesions are circumscribed and often surrounded by reflex erythema. The disease frequently presents with angioedema, a localized swelling of the subcutaneous or submucosal tissue. This image shows the resulting increase in vascular permeability on the back of a patient's hand. Angioedema commonly affects facial tissue, such as the eyelids and lips. This periorbital swelling significantly impacts patient quality of life, often causing burning or painful sensations rather than itching. While these outward signs are easily recognizable, they represent the endpoint of a profound cellular dysfunction that spans an entire spectrum of chronicity. Acute urticaria is defined as a self-limiting condition lasting fewer than 6 weeks. It is typically a transient response to viral infections, medications, or specific dietary triggers. When symptoms persist beyond the 6-week threshold, the diagnosis shifts to chronic urticaria. This systemic condition requires an ongoing strategy focused on long-term clinical control. Chronic urticaria is subdivided into 2 primary endotypes: Chronic Inducible Urticaria, or CINDU, and Chronic Spontaneous Urticaria, or CSU. In CINDU, symptoms are driven by specific physical triggers, such as extreme cold, friction, or sustained pressure, which can be confirmed through provocation testing. The most prevalent subset is Chronic Spontaneous Urticaria, occurring completely unprompted. CSU affects up to 1.5% of the population in the USA and Europe, with higher rates reported in China and Korea. The demographic peak for CSU occurs in adult women over the age of 30, who are significantly more likely to be affected than men. Effectively treating the relentless flares of CSU requires clinicians to look beyond simple external allergies and investigate the autoimmune dysregulation of the mast cell. The skin mast cell is the central orchestrator of urticaria, residing deep in the dermal matrix near sensory nerves and blood vessels. The key to activation is the Fc-epsilon-R1 receptor on the mast cell's lipid bilayer. In the type 1 autoallergy endotype, errant IgE autoantibodies bind to these surface receptors. When autoallergens cross-link these complexes, they initiate an immediate activation pulse traveling into the cellular interior. Type 1 autoallergy identifies chronic spontaneous urticaria as a self-sustaining immune loop targeting the skin's own defense infrastructure. The second endotype is type 2b autoimmunity, where IgG autoantibodies directly target IgE molecules, or the Fc-epsilon-R1 receptors, forcing them into a cross-linked state. This cross-linking forces an intracellular signaling cascade involving the sequential phosphorylation of tyrosine kinases, Lin, SYK, and crucially, BTK. This cascade leads to rapid and massive mast cell degranulation, where preformed mediators are released into the extracellular space. The released histamine immediately binds to sensory nerves to induce severe pruritus and acts on blood vessels to force extreme vasodilation. A secondary wave follows as the mast cell releases cytokines like TNF and IL-5, recruiting eosinophils, basophils, and Th2 cells into the dermal tissue. This cellular machinery creates a localized, self-amplifying inflammatory loop, explaining why simple over-the-counter interventions fail to stop chronic disease progression. Clinical management of CSU requires strict adherence to an objective, stepwise escalation algorithm. Treatment decisions are guided by validated patient-reported outcome measures that track disease activity and quality of life over time. Step 1 involves the administration of standard-dose second-generation H1 antihistamines. Pharmacologically, these drugs act as inverse agonists, shifting the H1 receptor into an inactive conformation. International guidelines recommend aggressively updosing these antihistamines, up to 4 times the standard daily dose, before declaring treatment failure. Despite high-dose inverse agonism, the continuous mast cell degranulation in roughly 1/3 of CSU patients overpowers step 1, necessitating biological intervention. Step 2 for inadequately controlled patients is the introduction of the biologic therapy omalizumab. Omalizumab breaks the activation chain by binding to free-floating IgE, neutralizing the type 1 autoallergy pathway and actively downregulating the expression of Fc-epsilon-R1 receptors. Highly refractory cases that remain symptomatic despite biologic intervention move to Step 3, the introduction of cyclosporin. This step is typically required for patients with type 2b autoimmunity, who often present with low baseline IgE and positive basophil activation tests. Cyclosporin functions as a potent immunosuppressant, dampening T-cell activity and directly suppressing mast cell mediator release. Thanks for watching. Please like and subscribe. Computational Genomic Biology. By identifying the underlying molecular endotype, be it type 1 autoallergy or type 2b autoimmunity, clinicians can map the patient to the correct algorithm step to achieve total disease control.